Okay, so this patient was born 1950. She presented just recently in August in our emergency department because of coffee ground vomiting. She was hemodynamically stable when she was admitted. She claimed that she had hepatitis B in 1968. In 1979, she had a liver biopsy. Probably this was chronic non-A-non-B hepatitis, which was later then confirmed as being hepatitis B. She was never treated. She's a special person. She grew up with foster parents after she committed a suicide attempt. She was then sexually abused. She has no IV drug use and no blood transfusion. She had a regular alcohol consumption of up to 10 deciliters of wine per day. She lived alone. She's divorced, has no children, and she worked as a nutritionist. She was outside misdiagnosed as hemochromatosis. She was for a long time undergoing regular phlebotomy. These were her lab values at admission. Obviously, everything is almost red. You see the severe anemia due to vomiting, upper GI bleeding. She's thrombocytopenic. She has a slightly prolonged INR. She has a low albumin, elevated liver enzyme. And then we repeated all the serologies. She never had hepatitis B. Obviously, she was hepatitis C positive, genotype 4, with 740,000 international units per ml, genotype 4. This was her ultrasound, clearly showing signs of cirrhosis already with a slightly enlarged spleen. We heard about the FibroScan cutoffs for cirrhosis. She was at a very high FibroScan of 36.3 kilopascal. She had small esophageal varices at endoscopy. So we made the diagnosis of a decompensated liver cirrhosis, child PUP8, MELD score 13 at the time of admission due to hepatitis C, genotype 4, and alcohol. She had ascites that you saw on the ultrasound, just like thrombocytopenia, small esophageal varices. Actually, we planned to treat her with velpatasvir fosfovir plus ribavirin because she was decompensated. She got an outpatient appointment. She sent us then a very nice letter that she would like to cancel this appointment. I called her then and asked her, why did you cancel the appointment? She said, you know, I'm feeling perfectly fine. I am afraid that these drugs will hurt my liver. I don't want to undergo this treatment. And then we discussed about side effects of treatment and so. I mean, the only thing I managed to achieve was that she agreed that she will read this up in the internet and get some information. And she told me she has a medical background herself and she knows what's good for her liver and not. So at the moment, she's still untreated. We will see whether we manage to get her into care in the near future. The second patient is a 1958, but also female. She was referred in June for treatment of biopsy-proven HCC. This case fits very well what you, Professor Rockstrom, mentioned before regarding blood transfusions. She had a blood transfusion in 1979 during surgery for an extrauterine pregnancy. 2017 diagnosis of Hep C was made. It's also interesting that her husband is working as a physician. In 2019, there was a suspicion on the CT scan of cirrhosis. And on 2021, she was referred then to an outside gastroenterologist 4 years after diagnosis to initiate treatment. And when he did the ultrasound, he found the HCC and he referred then her to our unit. These are her lab values. She had a genotype 1A, slightly elevated liver enzymes, also cirrhotic, slightly elevated AFP, going well with this biopsy-proven HCC. We treated her with velpatasvir fosfovir for 12 weeks. She achieved SVR 12 just a few weeks ago. And we performed microwave ablation of the HCC. Her first follow-up MRI showed no residual tumor, so she might be on the more lucky side. The third patient, also female, I don't know why there are so many female patients that are presenting late. She's born 1966. She was a year ago, she was referred to us by her family physician with a suspicion of liver cirrhosis, most likely hepatitis child B. She had newly detectable ascites and peripheral edema. That's why she went to see her family physician. She gained weight, 5 to 10 kilograms over the last 4 months. no fever or sweating. She had liver signs on clinical examination, like pulmonary edema, spider navy. An ultrasound performed by the family physician already. A suspicion of cirrhosis with irregular surface around the liver edge and approximately 2 liters of ascites, slightly elevated CRP, leukopenia, and also thrombocytopenia. The suspicion by the family physician was mostly alcohol related, as she drank 1 to 2 liters beer daily. When you talk to her, she was an ex-IV drug user. That was very early in the IV drug use time in Zurich on the blood spitz. In the early 80s, she actually achieved to self-detoxify her. And you have to remember, early 80s in Zurich, there was still illegal to distribute syringes and needles. And she then got out of the drug dependency. She was working regularly, full-time. She was not married. She lived with her parents. She was always healthy, and she did not see her doctors for years. I think it's also interesting, her brother works as an ICU nurse, and then when we asked her, why did you never go for testing? She said, well, I felt always healthy. I thought I did not get it. That was her lab values. Also, she was already thrombocytopenic, prolonged INR, elevated liver enzymes. And when you did the testing, not surprisingly, you also find chronic hepatitis C, genotype 4. An ultrasound, also, she had already an HCC at the time of presentation. 3 centimeters. We made the diagnosis also of a decompensated liver cirrhosis. Child C at the time of presentation, MELD 17 points. Due to hepatitis C and alcohol, she had portal hypertension, ascites, splenomegaly, thrombocytopenia, and an HCC with no varices. Her course was quite complicated. We worked her up for liver transplantation. We did TACE to get the cancer under control, but she developed recurrent large volume ascites that required paracentesis. She went into a kidney insufficiency. We tried to reverse this by implanting a TIPS. And in October, she was always in the hospital from August to October. She had to be transferred to the emergency unit due to hemorrhagic shock with intraperitoneal bleeding. They found small and large bowel ischemia as well as liver ischemia on the CT scan, and 1 day later she died from liver decompensation. And the last patient is present also last year. This is the only man, 1965. He was sent by his family physician because of lower abdominal pain for a CT scan to an outside radiological institute. And he had slight tenderness on clinical examination, no fever. And the diagnosis by the family physician was suspicion of perforated diverticulitis. Then our emergency station got a call from this radiology institute in the city that this patient had a portal vein thrombosis. He had bilateral large adrenal masses with suspicion of bleeding into the adrenals, a thickened gallbladder wall, and no evidence for a large bowel pathology. You see here the CT scan. I don't know, is this working? I don't think so, but what you can see here is the portal vein thrombosis, and on the MRI, you see a very irregular parenchyma on the left liver lobe, and we biopsied this lesion, and it was a diffusely infiltrating HCC with tumor thrombosis of the portal vein with hemangiosis carcinomatosa. He has almost the same history. He was at the same time on the blood spitz, used drugs, came away himself, was also always working full-time. He lived alone. He almost never saw a physician because he felt healthy. He told us the same thing. I never went testing because I thought I'm healthy. I don't have any complaints. He has one child from a relationship. These were his lab values. Interestingly, AFP was almost normal, but also he had a severe portal hypertension with thrombocytopenia. Obviously, when you looked for HCV, also with him, we found an HCV infection genotype 1B. He had a very, also his diagnosis, decompensated liver cirrhosis, chronic hepatitis C, portal hypertension with all the complications, including an HCC at time of presentation already BCLCC. So that means advanced cancer that can no longer be treated in a curative way. On further workup, he had lumbar spine metastases. He had a pathological fracture of the femoral neck that was surgically repaired. After the operation, he decompensated, was admitted to the ICU, developed gram-negative sepsis, and 1 day later also he died in the hospital after a few weeks after diagnosis of Hep C. So if we summarize these 4 cases, the first patient was born 1950. We don't know exactly when she infected herself, but the diagnosis was made in 1979. After 42 years, she presented with liver decompensation. At the time, she is still alive, but untreated. The second patient had a blood transfusion in 1979, had 38 years later the diagnosis. 4 years later, she presented for treatment for hepatitis C and is now cured, but has an HCC as a complication of liver cirrhosis. And the last 2 patients developed somewhere in the early 80s. The infection presented 35 years later with Hep C, decompensated cirrhosis, diagnosis and death almost at the same time. And also the last person, the male patient that I presented, almost the same history with a very short interval between diagnosis and death. These are my 4 cases.
Thank you very much.